I've seen a lot of discussion, posts, talking. I talk a lot about it. Positive pressure in heart failure,
Hmm.
left heart failure, right side heart failure. Positive pressure, I think, is like a general umbrella too, which I feel like to some degree you can talk about non-invasive and the ventilator,
Hmm.
right? Because you're sort of like getting the same sort of stuff. But maybe before, Willard, we dive into that, you can tell everyone who you are and what you do. That way, they're not like, who's this random dude that's
Which is
talking
random.
about positive pressure ventilation?
Sure. I'm Willard. I am a critical care cardiologist, structural echocardiographer, and a pulmonary hypertension specialist. So I trained in critical care and then I went back and I did cardiology training. And so I have a particular passion for the heart and the heart in critical illness and how varying things that we do to people and to patients really impact the cardiovascular system and vice versa.
So goes without saying that you might have a little bit of expertise in this situation, like a patient with heart failure who we're going to start on positive pressure.
Yeah,
Not
I
only
definitely have a
not only
bias.
from the heart side, but from on like the ventilator, mechanical ventilation side as well, I
I
suppose.
think that's probably a fair thing to say, Nick.
That's fair. Okay, good. That's an accurate description. Perfect. So I'm gonna make up a case,
Hmm.
but I think it's like, this is part and parcel to, I mean, anyone really. So you have Mr. Lee, who is a 59-year-old male, ton of past medical history, including heart failure, takes a little bit of the liberty on maybe, eating more salty stuff than normal, is not really taking his medications, et cetera, et cetera. He becomes tachypnic, tachycardic, hypoxic. You find him, and you meaning, I feel like it could work at any level, from like an EMS level to an intern level to a resident level fellow, like attending anyone, RT, et cetera. You find him breathing, very tachypnic, using accessory muscles. He's got elevated JVD for whatever that's worth. You maybe feel his legs and they're on the cooler side. And is there some edema? Maybe like +1, +2. It's pitting. You listen, he's got crackles. So as a part of your sort of multi-pronged approach to this patient, you decide to start non-invasive positive pressure. So, and I'll let you sort of, I'm sure you have a spiel in your mind, which is fine because I'm sure it'll be brilliant. But, non-invasive positive pressure in this situation, like the failing heart, as an idea, what are we trying to achieve, I guess, is a question.
Yeah. It's really interesting because I think in medicine, there are a lot of rituals, and your first few years as a trainee is learning the ritual.
Yeah,
And
good point.
then, like, when you get to the fellowship level or the attending level, you have the ability to go through and dissect the ritual and understand why you're doing it. I think if
Right.
you were to ask almost any intern by this point in the year, they would give you the ritual for acute decompensated heart failure exacerbation, which would be
Okay.
positive pressure ventilation, diuretics, nitro drip, right? Like, how
Yes.
many times have you written that in a note?
Yeah.
Probably
Yeah.
like 1,000 times.
Yeah.
So there's a, like an actual reason why we do all of those things, and it really boils down to afterload. And
Okay.
afterload, to my mind, is like a very interesting concept in general. There are a bunch of different models for afterload. Like the simplest model for afterload is like a dude curling iron, lifting
Right.
weights.
Right.
And that historically has been how we modeled afterload. We used Hooke's law, which was a weight attached to a string attached to a like manometer to model how afterload changes. But like the heart is not a like arm doing a bicep curl. It's a very different structure, and it resembles something called a prolate ellipse, or
Okay.
at least half of a prolate ellipse. What is a prolate ellipse? A prolate ellipse is a bullet. So the heart looks like a bullet. And I think that's like
Sure.
intuitive to most people who have done like point of care ultrasonography, right? Like you look at the heart and it like at least the left heart looks like a bullet. So, the LV shape really resembles that. It geometrically resembles a prolate ellipse. And as a result of that, we can use Laplace's law. So I'm sorry, I'm introducing math like so quickly in
Yeah.
our
No, that's
discussion.
that's the best thing about you is that you introduce really complex physiologic concepts with very old guy named like laws, and then sort of like, do the old razzle dazzle, and then we're like, well, we get to Ohm's law somehow through
Yeah,
here,
yeah,
but
exactly, right?
yeah. Okay.
So,
But never
I
anyway,
actually have a slide on this if you would like. I think it works better visually. Is that okay if
yeah.
I share my screen, Nick?
Yeah. I think
Is that
I
all
don't
right?
Yeah, you can. You might have to share the window if you hit share and
I'll
then
share the
window.
window for
Yeah, share.
sure. Let's see if I can share the window. Here we are. Okay. So can you see this okay? Yeah. So like
I
there
do
are a
see it
lot
okay.
of yeah, so there are like a lot. So afterload, as I said, like is one of those concepts where you know it when you see it,
Right.
right? And we talked about muscle lifting weights, but there's a
Yeah.
bunch of different models for afterload, including like all the way up to elastance and
Okay.
NP spectra, which is something that we talk about, but we don't like conceptually think about too much in clinical practice. But today we're going to talk about afterload as wall stress, the stress that a wall has to be under. Okay.
Okay.
And so like the LV, if you look at it, really looks like half of this structure. And that's that prolate ellipse structure that we're talking about. It has two different radii, a major radii and a minor radii, right? And if you like look at the heart under echo, right? Like that's kind of what it looks like, right? Like it
Right.
kind of looks like a prolate ellipse, right? You have the left ventricle kind of looks like has a minor radius and a long radius, like has a length and a radius. Um,
Right.
and because of that, like you can actually model this using Laplace's law. And Laplace's law takes the ritual of what I'm going to do in heart failure exacerbation and makes it concrete and explains why you do those things. This is, I promise you, there won't be too much math here. I promise you.
Okay. Yeah. I'm gonna hold you
So
to it.
yeah, definitely do. But this character right here is wall stress, right? So
Right.
wall stress is the amount of stress at any particular point of the wall is exerted that has like exerted on it. And you can imagine, right? Like higher wall stress, higher afterload. Okay.
Right.
Um, so wall stress right here, as it says, is it's dependent on how big that cavity is. So there's an implication here, right? Somebody who has a dilated cardiomyopathy, just because the radius is bigger,
Hmm.
means that they are higher afterload. Just by having a larger chamber, they have higher afterload because they have higher wall stress. The other thing it's dependent on is the wall thickness. And this is, again, I think somewhat intuitive to anybody who's taking care of someone who has like long-standing hypertension or end-stage renal disease. Those people have really thick walls,
Right.
right? Why do they have really thick walls? They have really thick walls because they are constantly under constantly have higher blood pressure. They constantly have higher wall stress. And so their compensatory mechanism is to hypertrophy, is to
Mm.
get bigger. And as a result of like the walls getting thicker, you end up reducing wall stress. So when you see that person who's on dialysis, long-standing like hypertension, and you see them having thick walls, like that's a marker for somebody who's had long-standing like high wall stress and high afterload. But what's interesting here is that the other part that's really cool about this and gets kind of to what we're talking about is this what's called the transmural pressure gradient. And all that is that's the pressure outside the heart minus the pressure inside the heart. Okay, so
Okay.
what do I mean by that? Right. So we can use this to understand like afterload. And so we talked about how people who have like dilated cardiomyopathy have higher afterload just because their wall is bigger. We also talked about how like thicker walls will reduce that wall tension, that wall stress, and that's like LVH. But there's also this idea that the higher pressure gradient between the inside and the outside really increases wall stress. And as you talk about all the time, right, the pleural pressure, the pressure inside the lungs is really transmitted to the pericardium.
Right.
And you can approximate your pericardial pressure by understanding what your pleural pressure is. And so you can imagine a situation of respiratory distress where you have those rapid swings in your pleural pressure. That's
Hmm.
rapidly changing your pericardial pressure and is rapidly changing this number up here, that transmural wall pressure, right?
Okay. Yeah.
And so as a result, it's rapidly changing the amount of stress the heart is exposed to. And so, um, under normal conditions, like you and I breathing, right? Like with a pleural pressure of -5 and a pericardial pressure of -5 and an LVN systolic pressure of like 120, right? Like that's not that much of a change in transmural pressure, right?
Right.
Super easy. But like imagine somebody in bad heart failure who maybe has a pressure in the 90s and who is in respiratory distress
Hmm.
and who is like really tachypnic and is really changing how much they are like how really changing their pleural pressure a lot, right? And you can get to a pleural pressure of -20, right? So like
Now,
that's
when you say -20 as opposed to -5,
yeah,
that's because they're dropping their diaphragm aggressively, and then
yes,
that pleural pressure gets more negative?
that's correct.
Ah, okay, I see
That's
what you mean.
correct. Yeah. So if you're like taking a huge breath in and like you hold it, that's called a Mueller maneuver. So if you
Right.
do that, like you can get to pleural pressures of -20 and
Mhm.
pericardial pressures of -20. And like as a result, like that's all LV afterload that you're seeing, right?
Right.
And so like when you have that, you can actually drop your cardiac index pretty substantially. And they've done this in healthy volunteers. They've taken like people who are like us and they've made them do these Mueller maneuvers, these sustained inspirations against a fixed and closed glottis.
Right.
And what they saw was that they actually could take their cardiac index and de-drop it from like 3 to 2.6. So you can imagine your patients who are in like borderline cardiogenic shock because they're in, like you mentioned this guy who has cold legs,
Right.
who is kind of maybe walking around in like low level cardiogenic shock. And like they're in respiratory distress. They're dropping their pleural pressure to -20. And they all of a sudden have massive swings in their pleural pressure, massive swings in their pericardial pressure, and they can drop their index like this.
Right.
So what do you do when you put positive pressure on someone? You actually increase the pressure in their pericardium because you're
Mhm.
increasing the pressure in their pleural space, and you make the pressure gradient between outside the heart and inside the heart much lower. So if
Mhm.
you put this person who has an LVN systolic pressure of 90 on 10 centimeters of PEEP, what you've done is you've made this pressure gradient 80 rather than a pressure gradient of 140, which would be this case. So that's kind of how positive pressure can help the heart. It also gets the idea of like, hey, maybe we should be trying to avoid ventilator asynchronies in these patients, right?
Right.
Because the more ventilator
Yeah.
asynchronies, the more asynchronies they have, the harder they're working to breathe. All that stuff ends up like being transmitted to the pleural space and the pericardial space. I'll stop sharing. I can't promise you I won't share again, but I'll stop now.
Oh, you can well, no, that was great. So what you're saying is that the transmural so what a and that transmural pressure decreasing the gradient, is this how so when I tell learners that positive pressure helps a patient in like left side of heart failure, I think of it I sort of try to break it down to three things, which is and maybe the afterload one you can sort of expound on more, but
Yeah.
the one where it's contractility, I say it positive pressure helps the heart contract because you're sort of like squeezing around it. Which I
Yeah.
guess it did you just show us the mathematical model for why that what I've been saying for 5 years is not is actually true and
That's
not just
actually,
me,
yeah.
like, spouting
Oh,
off?
100% correct.
Okay.
Yeah, so that's that's what this is what you're doing, right? So when you add PEEP and you add positive pressure, what ends up happening is you raise this pericardial pressure.
Mhm.
And every breath you give raises the pericardial pressure during inspiration and drops back to PEEP during expiration. And as a result,
Ah,
there's that
right, right.
lower pressure gradient between your end systolic pressure and your pericardial pressure. These two numbers are closer together than farther away during inspiration.
Now,
If
actually,
you're slow.
that's a good question. So, alright, a follow-up question would be, um, does it m so then does that and I think the age-old question becomes BiPAP versus CPAP only.
Yeah.
But it sounds like it sounds like maybe BiPAP would be better because during inspiration, you go to that higher pressure, so the gradient would be even less. Is that
Yeah, it's a
safe to
good
assume or no?
it's a good question. I know they've done, like, trials of BiPAP versus CPAP in people with, like, chronic heart failure, and BiPAP did not perform that well. They actually did worse, um, for reasons that are very complicated and I think have to do a lot with trial design. Um,
Okay, okay.
However, I think that if you're one of the advantages you have in BiPAP, and specifically in these patients who have cardiogenic shock and worsening respiratory failure, is that you also mitigate their work of breathing.
Right,
So, like, as you know, like breathing requires tremendous amount of work,
right.
and if the h- if you are breathing and you're changing that transmural pressure, if your transpulmonary pressure having a lot of swings, what ends up happening is that you end up burning a lot of that metabolic fuel that the body relies on, and the heart also relies on, has to sustain. And so when that happens, like you can worsen your shock, you can worsen your lactic acidosis, you can develop, a lot of times these people also have pretty significant mitral regurgitation. And
Mm,
so, that results in fluid back up into the lungs, dropping and falling compliance. When compliance falls, you also have increasing work of breathing. And that increasing work of breathing is, places that, results in worsening acidosis, hypoxemia, all of which the heart does not like.
and the thing
Sure, really. Yeah, go ahead. Sorry.
no, no, the thing that I also say to learners and that you've you have said beautifully is so when it comes down to it, that is, increased worker breathing. Like that is, I think this happens more for COPD, but it could work, works for any pathology. When we say, their patients tiring out, I mean, that's the tiring out, right? When you're expending so much energy
Yeah,
just to drop your diaphragm for whatever reason, whether it's compliance issue, resistance issue, whatever, and you start to get this lactic acidosis buildup because you get more anaerobic, you get a higher lactate, you get more acidotic, you get more metabolic acidosis. Everything works worse in acidosis, as you mentioned. So like that is the end result of these things, and then that is what tiring out, quote unquote, is. So
that's right.
for many reasons, applying positive pressure helps the worker breathing by decreasing the amount of. I mean, I think when you would probably agree, it just decreases the amount of like delta P that we have to contribute to sort of like move the mass to get the volume. Does that make
That's right.
sense?
Yeah, no, that I think that makes a ton of sense, and I think that, a lot of times these to my mind, when you have heart failure and you're using positive pressure, you're doing 3 things. 1, you're reducing RV preload. You're putting volume in the chest that's blocking the inferior and superior vena cava from returning as much volume to the right side of the heart. When that happens, the left side has less preload, which means left side's end diastolic volume is less, which means that
Mm,
maybe it's better on its Starling curve. The second thing you do is you allow the heart to empty better by reducing its afterload, by reducing its wall stress. So it can eject
mm,
more. And
right.
that's kind of what a balloon pump does, right? So
Yeah.
positive pressure is kind of like a mini intra-aortic balloon pump. And the third thing is that it reduces the work of breathing. The work of breathing imposes tremendous amounts of metabolic demand on the body as a whole. And that if you can relieve the acidosis, if you can relieve the hypoxemia, maybe you have better RV and LV function, which I think helps significantly.
Now, if Mr. Lee
Yeah.
has, let's say he has pulmonary edema over like,
Yeah.
I mean he has pulmonary edema, not he might have, like he does have it. There this adage of, and I'm guilty of it myself, that positive pressure sort of like pushes fluid out of the alveolus. I think it's too simplistic
Yeah.
maybe. Is
Yeah.
there a more sort of like elegant answer to that we can sort of expound on?
Yeah, yeah. I think that that's one of those. I mean, I hear the house staff say that a lot. I think
Yeah.
that's physiology that's physiology that I have yet to conceptualize. I don't understand how putting air or 5 centimeters of air into an alveolus pushes fluid that is proteinaceous back into the vascular space. I just don't think the physiology works like that. I think more accurately what happens is that you have that reduction in the LV can eject better, and you also get less mitral regurgitation. A lot of
Mm,
these people, when they have these big dilated hearts, they have pretty bad MR
okay. Right.
because that, like, as your heart gets bigger, right, your mitral annulus is like a fibrous structure, right? And you start pulling that apart, those leaflets get farther and farther from each other and they leak more and more. And so as you reduce your systemic afterload and the heart can eject more, you get less mitral regurgitation. There's this like really cool study that they did during MitraClips where in Germany, and it was published in like 2016, and they looked at what sequential PEEP changes do to the physical geometry of the mitral valve. And what they found, and they went really high. Like, I mean, they did like recruitment maneuvers on these people.
Wow.
I mean, they took the PEEP from like 5 centimeters of water up to 27 centimeters of water, which is, I think, higher than any of us would go. But
For
what they
sure.
found was that as they increased the amount of PEEP, the mitral valve ended up coapting better. So you had a better seal on that mitral valve, less
Mm,
leakiness. And as a result of that, you have less like backflow of blood into your lungs. Now, all this was during a mitral valve like procedure. I don't advocate for anyone to go up that
right.
high on
Yeah, yeah.
PEEP.
No, we're not. Yes, we're definitely not
No,
advocating 27 meters of water peep. However,
it
this,
does illustrate the physiology.
yeah, no, well, here's a question that I have for you. And this is sort of like something that I do, which is if I see someone on BiPAP, let's say, and they, it's cardiogenic, it's pulmonary edema and cardiogenic, not cardiogenic, whatever you want to call it.
Mhm.
I guess cardiogenic because we'll stick with that. But and they're on like sort of the settings du jour, 12/5,
Sure.
10/5. I sometimes preferentially go up on the EPAP
Mhm.
instead of really the IPAP because I am trying to affect like a mean airway pressure change kind of overall rather than like supplying more IPAP. And
Yeah.
that I don't know, it conceptually makes sense to me, but can you, like, either dispel that or maybe support it? I'd rather
No,
you
no,
support it honestly, but I'll
you'll
take
settle
either.
for either?
Yeah, I'll
I
settle
I
for
mean, I
either.
think that makes sense. I think if you're increasing the IPAP, what you're doing is you're allowing for larger tidal volumes to
Right.
mitigate some of the work and allowing for some of, like, the work shifting. So you're allowing for a
Sure.
patient to, like for that patient to the machine to do more of the work of breathing and the patient to do really only the triggering work. I think
Sure.
going up on the EPAP actually makes sense for a couple reasons. One, you're recruiting more lung tissue. And so as you
Right.
recruit more lung tissue, maybe you have a little bit less of that shunt fraction of like, and by shunt fraction, I mean more in like the pulmonary world where like
Sure.
blood going through the lungs rather without receiving oxygenation. So I think if you go up on the EPAP, right, you recruit more lung tissue. Maybe that's better. Maybe you get better oxygenation. Number two, I think that, as I said, like you reduce your LV afterload by reducing that transmural pressure gradient and
Right.
allowing for like less afterload, the LV to eject better, and like kind of like that mini intra-aortic balloon pump concept of which
Right.
positive pressure is. And then you get less mitral regurgitation as you sort of have a little bit as like the LV can empty better. It has a lower end diastolic volume. The mitral annulus is better, like is smaller, and like the mitral valve can coapt better, which means less MR, which means um, less pulmonary edema in the future. And then I think the other thing is you also return less blood. You have a little bit of a less of a return of less of blood to the right heart. So I think that makes a lot of sense to go up on the EPAP there.
So what we're
Absolutely.
So what we're talking about in at least left-sided dysfunction would be really this transmural pressure that results in the heart squeezing better, less MR, as a function of the PEEP or the positive pressure in the chest, sort of less return of blood to the heart. And then, as you mentioned, the other thing, which ultimately leads to like less end diastolic volume, which is something we sometimes target, I guess, like not target, but if you have a cath and like they report like the end diastolic volume was X, and we're
Mhm.
like, oh, the EDV was, 30 or 40, like, we better diurese the bejesus out of him, but, like, I don't know, as a number, I don't know how functional it is all the time because it's not something that we usually get, but certainly if someone comes back from the cath lab, that's something that we think about.
Yeah.
Mm,
And I think that's like, when I'm dealing with people who have like impellas in, right?
sure,
And I like see the wedge is like, if I see the wedge is like 25 and my CP is 5, I'm like, oh, they're just not unloading well. I'll try to
right,
unload them more by going up on the P level on
right.
the impella or, by adding some nitrite. So I agree. I don't think it's like something I like that maybe we may not clinically follow in all of our patients, but I think it's a helpful framework to understand like the EDV and EDP are high, like that's somebody who needs to be unloaded a little bit more, and why loading the ventricle with volume and pressure can result in a higher afterload in and of itself in the absence of everything else.
And, let bless Mr. Lee with now right-sided dysfunction.
Yeah.
No, does that change things for you? Like, as far as or maybe biventricular dysfunction might be more like, I guess, I don't know if that'd be more controversial to some degree because, you wanna put on positive pressure, but then you're sort of worried about the right-sided portion. Like, how
Yeah.
you change your calculus with that or not really?
Yeah, I think it's a really good question. And I think what you get at is a really important concept, which is that we're talking very broadly about what happens in physiology. And all of these studies were done in like a long time ago, in like the
Right.
60s,
Yeah,
70s,
yeah, yeah.
80s,
Right. Your
usually in
favorite
dog
your
models
favorite
and under
kind.
like, yeah.
Yeah.
And a lot of them were done in very isolated and laboratory environments. And I think like the important part of being a clinician is understanding like what's going on with your individual patient at bedside. And so I do think there's a real difference between somebody who's got like long-standing biventricular heart failure versus somebody who has like primarily group 1 pulmonary arterial hypertension in
Right.
terms of the heart-lung interactions. Those, I think, to my mind, those are very different patients, and I think they respond differently um, to a lot of our different therapies. And then just like that, I'll push back even more and say that, you know, right ventricular dysfunction, like probably the most common cause of RV failure in the ICU is ARDS. Up to
Right.
like when I was looking at the data, 25 to 50% of patients with AR right-sided dysfunction. I mean, that's a huge population. And that patient population, I think, responds very differently than somebody who has longstanding BiV dysfunction. So, to your question, I think you really got to get into like what happens to the right side of the heart. And that's like a little bit more complicated than like what happens to the left side of the heart. So, maybe can I share my screen again, Nick? Is that
Yeah, go
okay?
ahead. Go for it. Yeah, of course. Please.
I
Sure,
love it.
anything. Only
Uh,
because, we I'm never really sure where to put like, you have someone that maybe has group 1 pulmonary hypertension or
yeah,
I guess maybe any group except for 2 because that would sort of work against it, but and they're hypoxic, working to breathe, and there's always that knee jerk that you wanna put them on positive pressure, but it's like, "Oh, wait a second. I think they have RV dysfunction. Like, should we be doing this?"
yeah,
I think
yeah.
that's like a real that's a clinical bedside question that you need to really kind of, like, work through, I think.
You're absolutely and, like, that's I think it really depends on the underlying etiology and, like, like ARDS is the most common, and I think really a lot of sometimes our LV protective or our lung protective ventilation, ARDS, actually can make the RV a little bit worse. In your world, I know you're doing, some TT surgery stuff, like, cardiothoracic surgery in and of itself is a right ventricular insult, and it
Mm,
really gets into the idea that, like, it's the incision of the pericardium that results
mhm,
in the RV insult. Like, they looked at patients who, like they looked at the TAPSE in patients who were coming out of, the OR, after CABG, and, like, it dramatically falls, and if you identify the time point, like, when it falls, it's actually during pericardial incision. So, like,
mm,
it's not the induction of general anesthesia, it's not the sternal wound, it's the pericardial incision. You drop off, your TAPSE falls off then, and it takes a long time, like even after a month after cardiothoracic surgery for that RV to really start having a normal TAPSE again. Peach, as you talked about, I think one of the things that maybe your listeners will see more and more of as we start to move in this space is structural heart disease and tricuspid valvular interventions. So
right,
people who have long-standing bad TR are now going to be eligible for these structural heart procedures to fix that. And then in my world, also right ventricular infarcts.
right.
Honestly, sometimes there just isn't anything sicker than an RV STEMI. Those people
Yeah,
can be sick as stink. And then lastly, I would be remiss if I didn't mention pulmonary PEs. I think ARDS pathology is probably pretty well known to all your listeners. I don't need to go over like what happens to alveolar damage and how alveolar damage in of themselves can result in worsening transmural or just pulmonary pressure at different areas of the lungs. And over time, as you get into that fibrotic phase of ARDS, you get, you know, muscular, like pulmonary vascular remodeling, and an injury in that standpoint. I think what's more interesting is like, how do you manage this? And, to my mind, like you want to minimize RV afterload. You want to give sufficient, but not too much RV preload,
mm,
avoid hypercarbia and avoid hypoxemia. Um, and like, as you said earlier, RV contractility is paramount. And like, as I point out, like maybe these are like not the same goals that people who need lung protective ventilation have. Like sometimes, like, when you have somebody with like permissive hypercapnia or permissive hypoxemia, right? Like the RV is hurt by that. It doesn't necessarily love
right,
that. And people who have like maybe some RV failure on top of this don't do well with lung protective ventilation. Um, and like what I really want to talk about was like how the geographic relationship in the lungs alters pulmonary vascular resistance.
right,
Um, so you have different impacts of positive pressure on the right ventricle. Um, as you start making that pleural pressure more positive with mechanical ventilation or positive pressure ventilation, you increase the pressure gradient between your alveolus and your pleural pressure. And as a result, your alveolar pressure increases, right?
right,
Um, you also are going to decrease your RV preload, like we talked about. You're dropping the amount of venous blood that's coming into the heart. You also start increasing, you also change your west zone relationships in the lung. So west zone ones are areas of the lung where the highest pressure is the alveolar pressure. It's higher than the pulmonary arterial pressure. It's higher than the pulmonary venous pressure. And as a result of that, like blood is not getting through there very well.
mm,
West zone 2 is a zone where the highest pressure is the pulmonary artery pressure, but the next highest pressure is the alveolar pressure. So the gradient that determines blood flow here is the pressure gradient between the arterial and the alveolar pressure, not between the arterial and the venous pressure. And if you read a lot of the physiology textbooks, they'll talk about this as being the vascular waterfall of the lungs, behaving like a waterfall, where you can make the venous pressure lower and lower and lower, but it's not going to change the amount of flow. because the amount of flow is determined by the difference between the pulmonary artery pressure and the alveolar pressure.
Got
And
it.
then West zone 3 is the classic Ohm's law that we referred to, right? Our alveolar or arterial pressure is greater than venous pressure is greater than alveolar pressure, and the pressure gradient determines flow is between the arterial and the venous pressure. But
Right.
as you start putting positive pressure in the lungs, the proportion of like alveoli at that interface is actually much less and decreases, and you start getting more of a situation where you have like West zone 1 and 2, where your alveolar pressure is starting to determine the amount of blood flow. And so the last thing I'll mention about the RV is in like a really sick RV, as you start putting positive pressure and you start creating higher RV afterload potentially, you start shifting that interventricular septum from the right to the left. And so the RV gets bigger, the LV gets smaller, your stroke volume drops off.
Hmm.
Um, um, I'll go back one. I'll also note here the changes in pulmonary vascular resistance. So your pulmonary vascular resistance actually minimized at FRC. So the lowest PVR you get will be when you're just kind of relaxed. And as you start increasing the amount of volume in your alveoli, you get compression of the capillaries that run like around the alveoli themselves, but you get expansion of the capillaries that run between the alveoli. And so you're increasing PVR because you're compressing those capillaries next to the alveoli.
Right.
But similarly, as you get atelectasis, right, you start compressing those capillaries that run between the alveoli, but expanding the ones that are next to the alveoli, right? And so your PVR goes up through a different mechanism. So
Right.
your question's a good one. What happens if Mr. Lee has BiV failure? I would say for him, it's more likely that his cause of RV failure is probably it's probably long-standing LV failure, long-standing MR,
Sure.
long-standing high pulmonary pressures from that sense, what we would call group 2 pulmonary hypertension.
Right.
And that person probably has a significant amount of atelectasis. They probably have pleural effusions. They probably sit more over here, right? And so
Ah,
by
okay.
increasing their lung volumes with positive pressure, you might actually reduce their pulmonary vascular resistance.
Right.
If you took one of my patients who has long-standing pulmonary arterial hypertension, but nothing fundamentally wrong with their alveoli, and you admitted that person to the ICU, right? They might look more like this, right? Where they had very high PVR because they have pulmonary vascular remodeling, and putting
Mm.
them on positive pressure isn't going to reduce atelectasis. It's not going to open anything else up. It might just make them worse. And so I think it really does depend on the etiology of what's causing your RV failure to understand how you best are going to treat it.
So if
Sorry, that's a
you
very long-winded answer.
no, that was great. I was hoping you were gonna bring in the the PVR curve sort of like at residual volume and at TLC. But so I guess like to force you to put your chips down,
Yeah.
if you had someone with the latter, meaning you think it's more of like a, pure pulm hypertension driven scenario,
Mhm.
whether it's like, I don't know, group 1 or maybe get something more sexy like group 4 and they're in respiratory distress,
Mhm.
are you thinking twice like maybe we shouldn't put positive pressure here. We'll support them with high flow and pray that things turn around. Or are you going to roll the dice and put them on some PPV to see
Yeah.
if you can get some mitigation of their work or breathing, let's say, full well knowing, and I'm sure I mean, I know that what, RV dysfunction slash failure slash like that spiral. I mean, A, it happens quick, and B, it's very hard to rescue. It's like,
Yeah.
right? So I don't know. I find myself at times like, I don't know, like I really want to put them on positive pressure, but if I like that little tip, and they're like completely
Mhm.
off the cliff, it's so hard to come back from that.
Oh, yeah. And I mean, as you know, the RV death spiral is very, very real. I try my best to not intubate these people for a
Right.
variety of reasons, right? Because
Yeah.
you intubate them, you don't just give them positive pressure, you also give them sedation and you do a chemical sympathectomy on them. And
Right.
when that happens, they oftentimes are living on those catecholamines and they crash. And like if you look at some of the data on like these people who have like long-standing bad pH who get intubated, like they really do not leave the hospital. I think like something like on the order of like less than 10% of people who with like true group 1
Oh
pulmonary
wow.
hypertension, they do not leave the hospital. I think that I read in a very interesting paper from Chris Barnett, who I think probably is known to probably many listeners of your channel, who like looked at or who looked at this, and only 11% of patients treated with mechanical ventilation who have respiratory failure in the setting of PH survived a hospital discharge, and only 6% of those patients were alive after 90 days after hospital
Wow.
discharge. So I'm really trying not to intubate them. And, we can talk about, oh, maybe that's survival bias, right? Like you're only
Yeah.
intubating the sickest patients. These people are very sick. So I'll do my best not to intubate them. If I'm going to intubate them, I will not stop the pulmonary vasodilators. Like you don't
Right.
want to do it. And then, I do think there is a role for positive pressure ventilation here, Nick, mostly to help optimize, because a lot of times these people do have tremendous work of breathing that can be mitigated by
Right.
some positive pressure ventilation. So there was a nice study, I think in critical care medicine in 2017, which looked about how are you going to intubate? If somebody had to intubate somebody with PH, how are you going to do it? And
Right.
what they did was they did awake intubations, and they
Mhm.
used nasal CPAP to help
Mhm.
optimize their respiratory mechanics during intubation. And it gave them a bunch of vasoactives to help mitigate the SVR drop, and then did awake upright intubation, heavy topicalization with Optiflow or BiPAP, and induction with fentanyl and midazolam, maybe some ketamine. I
Right.
think if you're really thinking this person, they have group 4 disease, they're young, they're somebody who we can get through this, and they have respiratory failure, those are people I would put on VA ECMO, bring them to the cath lab and do a suction thrombectomy, and only when they're on circuit would I then intubate them, if they're in ECMO.
Yeah, yeah. No, I see what you're saying. And what was this? I want to ask you another. Oh, yeah. This is off the subject a bit, although on the same. But now that I have you in front of me, so I get a pure right-sided failure versus biventricular dysfunction. Let's just say either or. There's patients that are in respiratory distress for a number of reasons. They come to the ED.
Mhm.
How should inhaled pulmonary vasodilators be like some first line intervention?
Wow.
From I know this is like sort of a loaded question, I think, to some degree, but this is my concern, I'll be honest with you, is that I feel like these things are getting more in vogue to some degree.
Mhm.
And I'm just like, man, like I am a little nervous about this, just like throwing Flolan or nitric or what, I mean, just those two more or less, like on
Yeah.
everyone that we think that has pulmonary hypertension or even has pulmonary hypertension for whatever reason, and they're in respiratory distress, you're worried about their RV, let's throw some nitric on. Because a lot of times with this like biventricular dysfunction, like I'm a little nervous about making the RV squeeze easier to the left. And then you're sort of like down this rabbit hole. So should we be thinking about this more or just like,
That it
throwing it on for everyone?
I guess as a question to you, have you been following me around in clinic? Because I feel
No,
like
I haven't. No,
this
no,
is
I haven't.
constant. So I also do pulmonary hypertension clinic, and
Yeah.
this is I will say probably 50% of my referrals are for pulmonary arterial hypertension.
Right.
And you go through their chart and they don't have pulmonary arterial hypertension. Someone has read an echo or someone has read a CT scan that says pulmonary arterial hypertension based upon elevated RVSP or enlarged PA. But
Right.
in reality, most of these patients do not have PAH. Most of these patients have group 2 and group 3 disease.
Mm.
Group 3 disease, as you know, intrinsic lung disease. Group 2 disease, intrinsic heart disease. More people in America are obese, have
Yes.
OSA, or have obesity hypoventilation syndrome, have COPD, combined fibrosis and emphysematous lung disease, have HFpEF, have MR, have AS, have MS, than they do have true group 1 pulmonary arterial hypertension. I really worry about giving people
Mm.
with group 2 and group 3 disease pulmonary vasodilators, because you're absolutely right. What ends up happening is you give them a pulmonary vasodilators, you increase the nitric oxide supply in their lungs, all of those blood vessels open.
Yeah.
Most people who have a longstanding OHS or OSA, right, they have a reason to have high blood pressure in their
Right.
lungs. Their blood vessels are tiny because they have been deprived of oxygen and the blood vessels are doing their job. They're performing hypoxic pulmonary vasoconstriction. If you open those up, two things are going to happen. Like you said, you're going to get shunt physiology. You're going to take all that blood that was not going through the lungs, and you're going to move it through the lungs without getting oxygenated. You're going to make their hypoxemia worse. Number 2, you're going to flood their alveoli with fluid and you're going to make them a lot worse. And we've seen it pretty frequently, especially when we do this in patients with pulmonary veno-occlusive disease who might look like they have group 1 pulmonary arterial hypertension, but in reality, the problem is stenosis at their pulmonary veins. And like you open up those blood vessels, they hit that wall of pressure in the left atrium or at the pulmonary veins or in the LV or at the aortic valve or at the mitral valve. And all that pressure stays in the lungs and gets transmitted and gets dumped, and all that fluid gets dumped into the alveoli. And these people do a lot worse. So
Yeah.
I am very judicious with nitric and with Velitri. I really am, because I think that,
Mm.
I think in the right circumstance, it's the most helpful thing you can do. Absolutely agree. But I would say if you have a patient who's in your emergency room, who's an 86-year-old gentleman with moderate AS, who has an EF of 20, who has long-standing atrial fibrillation, who is an active smoker with maybe some underlying emphysematous lung disease, you will kill that person if you put them on nitric. They will do horribly.
Now, is that in the face of we've done an echo and the TAPSE is one and like,
Yeah.
they have moderate RV dysfunction. That I feel like
Yeah.
that's sadly echocardiography for all its, great features and advantages. We see, a mildly dilated RV and like, is there some septal dyskinesia?
Mhm.
Maybe the TAPSE is down. It's like, oh my God, I don't want them to go into the RV death spiral. Let's like put them on epi. Give them,
Yeah.
blah, blah, blah. Don't give positive pressure. And we should start inhaled nitric like right away or Flowland. So I'm good up until the inhaled nitric piece, only because like, as you mentioned, like you are going to pulmonary vasodilate them. You are 100% going to do that. The question is like, is that helpful?
Yeah.
So, if you have, and but I'll put my chips down and say, if I am fairly confident that they didn't have previous LV dysfunction for whatever reason, we have an
Mhm.
echo from 6 months ago or something, and it's like sort of normal, and now they have RV dysfunction. Like I might try it if I'm feeling spicy, but I feel like the inhaled pulmonary vasodilators were sort of like relegated to the ICU more. And then maybe with coronavirus, I'm not sure, everyone got more comfortable using them in that situation with like ARDS, which is different than like what I'm talking about. I'm saying like
Yeah.
someone, hits the door, they're in distress. You look at their heart, they have a dysfunctional RV and they're hypotensive. You're like, oh, this might be RV failure. Let me do X, Y, and Z, epi, high
Yeah.
flow, and like inhaled pulmonary vasodilator.
And Nick, they could just be hypotensive because they're hypoxemic or hypercapnic. The
Yeah.
RV, I mean, I've seen tons of RV that look like crap because their, PO2s are crappy and their PCO2s are high. And the RV is exquisitely sensitive to hypercapnia and hypoxemia. I think that echo is a great tool, but and the job of an echocardiographer is to answer the question. And I mean, there's a reason why we do full echoes on people.
Right.
The reason is like, if you just put your probe down and you're like, that RV looks terrible, I'm going to give them nitric. And that person has severe aortic stenosis, right? Like, yeah, their RV is going to look bad because the pressure is backed up into the LV, which is backed up into the left atrium, which is backed up into the pulmonary vasculature, which is backed up into the right ventricle, which is really good at handling volume, but really bad at handling pressure.
Right.
And so, I think that, and that my worry is that if you're a gambler and you play the odds, the person walking into the emergency department likely does not have pulmonary arterial hypertension that's
Right.
been
Right.
undiagnosed.
Because
Right?
it's incredibly rare. Like
It's incredibly rare,
it's
right?
incredibly rare.
Much more likely they have long-standing AFib and atrial myopathy, HFpEF,
Right.
severe AS, MAR due to for whatever cause, now, COPD. Now, that
Sure.
being said, there are patients, right? So if you have somebody who walks in who is a, sweet little lady who's got underlying scleroderma and, NSIP or UIP and, you're worried about like, and you're like, oh man, she's had declining DLCOs and her last DLCO on her
Right.
outpatient like PFTs were like 30%, like, and her FEV1 and FVC are normal. Like, what is going on here? Yeah, okay, that is maybe a different conversation to have,
Right.
But again, I think that's where your pulmonary vascular disease specialist really help you. Like, there
Yeah.
should be somebody, at a lot of institutions who have expertise in pH and who can help you and help you try stuff, in a very controlled fashion.
Awesome. So maybe
Yeah.
to just recap, because I have to let you go to clinic because you are
Yeah, I gotta see people with pulmonary hypertension.
yeah
And
with all my
as an aside, my
yeah.
clinic, which is pulmonary hypertension today,
Mhm.
has Like the 2 new patients I have, I've looked through their stuff. They likely have left heart dysfunction. Like that's
Yeah.
likely the cause of, and they're referred to pulmonary hypertension clinic for that reason.
Yeah. I feel like we can, a lot of things where the subspecialty clinics where even the pulm clinics, like my friend who's a you probably remember, he's out in Washington. He always talks about how he gets these COPD or asthma referrals for dyspnea, and you look at their echo and it's like the LA is,
Yeah,
massive.
massive.
It's like, I don't know. I
Yeah,
don't know if it's, asthma, but
maybe a long-standing
so
untreated AFib. Yeah,
exactly. So if you have so just as an so let's role play like, I'm
yeah,
you and you're the intern and I say to you, intern Willard, this patient has heart failure. We're putting them on positive pressure. How does it help?
yeah. So positive pressure will do a couple things. One, it will reduce your venous preload. It'll hopefully help tampen out a little bit of the IVC and SVC flow into the chest and
Mhm.
into the right ventricle. Two, it will recruit lung tissue, reducing hypoxemia and hypercapnia and allowing for mitigation of work of breathing, so less work of breathing. Three, it will reduce LV afterload, allowing for more complete emptying of the left ventricle on every ejection. And then as a result of that, it will also improve mitral annular coaptation and geometry, which allows for less MR, less mitral regurgitation into the pulmonary vascular circuit, and more forward flow in that direction. And this is helpful not just in the short term, but in the long term as well, which has been validated by multiple different studies of people who have been on CPAP for heart after they've had heart failure for a long time.
Wonderful.
Yeah.
Well, my friend, I appreciate your time.